All right, hello everybody. We'll quiet the music here for a second. All right, we're going to go ahead and get this session started. So it is my pleasure to welcome you to the Prophylaxis and Treatment of Invasive Mold Infections. So I just want to mention a few housekeeping items first. So you can find the complete speaker bios located in the HOPA conference app. And second, we ask you to hold all your questions until the end. I'll be coming around with a microphone to gather your questions at the end of the presentation. So it's my pleasure to introduce to you our faculty. So first we have Jim Lewis. He's the co-director of the Antimicrobial Stewardship at the Oregon Health and Science University Department of Pharmacy and Infectious Diseases. Second, we have Bernard Marini. He's a clinical pharmacy specialist at the University of Michigan Health System. And then lastly, we have Anthony Parasinati, who is also a clinical pharmacy specialist at the University of Michigan Health System. So please join me in welcoming them. Thanks.
All right, so this is the moment of truth. We find out if the clicker still works. There we go. All right, that's always question number one for these things. So thank you so much for being here this afternoon, and it is my pleasure to kick off this session with my co-speakers here. I think this will hopefully be a good time, and it is always a pleasure to be back in front of the HOPA audience. One, because these lights are so bright, they guarantee you I'm going to tell you the truth on everything, because you cannot lie under bright light. But two, guys, last time I spoke to you was 2 years ago. At that time, I requested that one of you, just one of you, come up to me afterwards and please explain to me the method by which you all use to Jedi mind trick P&T committees into approving expensive meds for formulary. Because with antibiotics, I get things thrown at me for spending $500 to $1,000 a day. Now you guys have taken it to a whole new level. CAR-T therapy at 450 GER? I mean, and the P&T committee at OHSU is doing this. I'm like, how do you people do this stuff? I remain extremely impressed by this group, and it's always a pleasure to be back. The faculty disclosures are up here on this slide in front of you. Nothing terribly surprising there, and we will all do our best to stay completely honest with you. And as you can see, we are inclined to beat each other up with this picture lurking down here in the bottom. The objectives. You're oncology pharmacists. You all pronounce blulimab in your sleep. I am extremely confident in your ability to read said objectives, therefore I am not going to read them to you, okay? There they are. And if you thought we're talking about blulimab, you are in the wrong room, okay? This is fungal infections. So, invasive mold infections cause problems in your patients. I greatly appreciate you all keeping us ID folks in business. Your ability to whack immune systems is basically unsurpassed. You bring in blulimab and whatever else it is you're choosing to use that day, and you wipe out neutrophils. You do all kinds of very cool things that place your patients at extremely high risk for some very cool infections. Who else, with the possible exception of your solid organ transplant brethren, have the capability to create patients that will mold? Right? I mean, that is the degree of immune suppression we're talking about here. But the problem is that these infections remain viciously complicated to diagnose. Our diagnostics in this area remain atrocious, despite the progress that we've made in diagnostic imaging, as well as in our drug therapies. And there's a lot of complications now with regards to our antifungal therapy, largely because the azoles all come with massive drug interactions. And they unfortunately interact with all of the compounds, or a lot of the compounds that you all like to use. So you not only have a horribly complicated host with a horribly complicated disease state with moderately good diagnostics, the drug therapy then gets further complicated because of all the drug interactions in play. One of the things that I want to do with this section before I kick it over to the brouhaha between these two, and you know, gentlemen, I was thinking, Michigan on Michigan crime, not that interesting. Michigan-Ohio State would have been a much more, I think there probably would have come to blows there, but I have great faith you two can duke it out. But USA versus Canada, that would work. Okay, so we'll go in that direction. But for the types of fungi, one of the things that I want to do is kind of set the table for these guys. And one of the things that you have to understand is that there are two large distinct groups of fungi. You've got your yeasts and you've got your molds. And especially for the learners or some of the younger practitioners in the audience, remember, never ever be the person that mixes up yeast and mold. Fluconazole is wonderful for yeast, but has absolutely garbage for mold activity. And really, when we start talking about yeasts in your population, it's almost always Candida, although it's important to remember that Cryptococcus, especially for those of us in the Pacific Northwest, remains an important pathogen. When you move over to the molds, guys, we're going to talk about several different molds here. But the fact of the matter is, the big bad elephant in the room remains Aspergillus. We talk about Fusarium, we talk about Scedosporium, we talk about the Zygomycetes or the Mucorales, but the fact of the matter is, at the end of the day, Aspergillus remains the major problem in this population. And the reason that molds are so pervasive and so common and problematic in this group is that as we are sitting here in Denver in this beautiful convention center right here with no oxygen in the room, I find myself panting a little bit already, we find that we're sitting here breathing in mold spores. They're everywhere. If we didn't have mold everywhere, nothing on this planet would decay and rot away, okay? And so mold is ubiquitous. It's everywhere. As we sit here, we're sucking in these spores, but we have these wonderful things that you all seem to be out to get called neutrophils. Why do you people insist on going after the poor neutrophil? What did it ever do to you, okay? But the absence of neutrophils, especially prolonged absence of neutrophils, places these patients at extremely high risk because they're continually sucking in these spores. And really, when you talk about Aspergillus, you know, we're going to spend the next few slides talking about the different types of molds. And Aspergillus is, you know, again, one of these filamentous, but it is septate. And so I think that's one of the things to really kind of take away as a marker. One of the major distinguishing factors between Aspergillus and the Zygomycetes is that Aspergillus is septate, whereas the Mucorales are typically considered to be non-septate or poorly septated. And so when you start to see these in tissue, that can be one of the kind of tip-offs that you're dealing with. Aspergillus fumigatus remains the most common of these organisms that we see, but it's important to realize that there are other species out there, and we actually had at Oregon Health Sciences this past week a patient with Aspergillus terreus. And the reason that these speciations become important is that in the example of Aspergillus terreus, remember, it's ampho-resistant. And so I think this again comes back to the point that we need our clinical labs to be identifying these to the species level in order to help facilitate optimal selection of drug therapy. Also, we're increasingly finding that a lot of these Aspergillus species are made up of subspecies, and so you're seeing families now, such as the fumigatus group, and so there's all this weird stuff going on in mold nomenclature right now. As we've touched on already, this stuff is everywhere, and really the way that your patients get into trouble is through inhalation of spores. The Mucorales are really probably one of the most feared fungal pathogens that we run into, with the Zygomycetes causing devastating infections. And the big thing for you guys to always remember about this organism is that it's intrinsically voriconazole resistant. You have no, none, zip, zero, zilch chance of covering a Zygomycete with voriconazole. It is just not going to happen. So when you see these, they tend to be late infections, and oftentimes they're in people who have been horrifically immunosuppressed for a long time and oftentimes have been on voriconazole for a prolonged period of time, kind of a selection type situation. There are a bunch of these Zygomycetes or Mucorales out there, and I will warn you that this group, probably more than any other in the mold area right now, is undergoing rapid and extensive renaming. And so really watch this. There's a lot of confusing movement within the naming. I'm telling you guys right now, the only thing more dangerous, in my opinion, than an oncology pharmacist who can say blablabla 5 times fast is a microbiologist with a PCR and time on their hands, because they sit around and rename stuff. And then we're like, wait, what even is that? And then you find it's the artist formerly known as, okay? And so you really want to watch in the Mucorales some of the renaming that's going on right now. Also, these molds really like to go to lungs, they like to go to sinuses. For those of you who've seen diabetics with invasive rhinocerebral, you've seen the destruction that can occur, and these are extremely tough molds to get rid of unless you can get immune function back. Fusarium. When you see fusarium, one of the things that I want you to notice here are the arthroconidia on this slide. We lovingly nicknamed these things in San Antonio, well, not so lovingly. We nicknamed them in San Antonio death bananas because to me they kind of look like bananas and they are associated with death. Okay, I mean, when you look at the mortality rates associated with fusarium, did any of you remember when we had the contact lens outbreak a few years ago? People's eyeballs are getting eaten. This stuff is merciless, tough to get rid of, and this stuff is basically resistant to every frontline antifungal agent you can think of. And so when you see this organism pop up, it's typically, again, in horrifically compromised hosts who've been on broad-spectrum azoles for a long time, who have not gotten immune function back. This is, to me, one of the nightmare pathogens, followed very closely by Scedosporium prolificans, which fortunately I seldom see, but is again one of those organisms that when you bump into it is almost always intrinsically resistant to all of your available antifungals. And again, all of these are associated with inhalation. Scedosporium is often associated with near drownings, but again, profound immune suppression, long time, and again, the presence of especially Posaconazole appears to select a little bit for Mucorales, Fusarium, and some of your Scedosporium species. Now, the reason that this is such a big deal is that when your patients develop one of these infections, basically the mortality rates for them are unacceptably high. Even with our best available drugs, as you can see from this slide, in the case of disseminated fusariosis, I want to know where they found a series of disseminated fusariosis that only had a mortality of 80%. I have never seen one of these patients survive. And people say, well, there's data with VORI. If you look at that data with VORI, the patients who survived had superficial infections, and the patients who survived got their immune function back. If you didn't have both of those, you were dead. Okay, and so I think fusarium, again, at 80% is probably a little bit optimistic. Scedosporiosis, again, if you've got prolificans as the causative agent, I would argue that that number is probably pretty close to 100 as well. So even though we've got newer antifungals available that we think of as being very broad spectrum and active, these infections still come with substantial mortality. And unfortunately, when you look at who is at risk for these infections, guys, I have bad news for you. Your patients are all over the top of this slide. Go to any invasive aspergillosis study done ever and find anybody without a heme malignancy in those studies. Those studies are almost exclusively dominated by heme malignancy because those are the patients who really are at high risk. Solid tumors, it's extremely rare to see these invasive mold infections pop up, and it's really the heme malignancies, especially the allogeneic stem cell transplants. And man, when you start to throw GVHD and long-term steroids, etc. in there, the risk just really ratchets up. When you look at the risk factors, all of this stuff that's sitting here on this slide is stuff that all of your patients are exposed to day in and day out. Again, prolonged neutropenia being probably the major driver, with a very close second being what I like to refer to as the witch's brew known as corticosteroids. High-dose corticosteroids long-term result in all kinds of dysfunction in the immune system that really place these patients at high risk, and we see this a lot in our graft versus host population. All right, there we go. And when you have patients on prophylaxis, the prophylaxis helps, but realize that even on prophylaxis, you still see breakthrough infections. On the yeast side, Candida glabrata remains problematic. We've seen in the literature a lot of the stuff coming out of the CDC about Candida auris being an increasing concern and being multi-drug resistant. And as we've kind of touched on already, voriconazole really doesn't cover the Mucorales, Scedosporium, Fusariosis. There are a lot of fungal infections out there, even though we're prophylaxing against a lot of the most common agents. The other thing that I want to touch on a little bit are some of the definitions. You guys will see these definitions all over the fungal infection literature. Guys, one of the things I want you to leave here with today is the understanding that these definitions were built to be used in research studies. They were not built to be used as, clinical type definitions day in and day out. And so be very careful about how you're hanging your hat on these, but it's important you're aware of them when you're trying to interpret or read the literature that's out there. And you can see that a lot of our patients are going to fall into the probable or possible definition, and this proven definition is kind of tough to get to because you actually have to have the organism grow, and as we're all painfully aware, getting organisms out of these patients sometimes is extremely difficult. The other area that we've kind of touched on a little bit already are some of the diagnostic challenges that we have out there. And again, how many of you are using 1,3-beta-D-glucan currently? There's a smattering of hands going up. For the hands that went up, raise your hand again if you actually trust it. Yeah, no, I don't see a single hand going up. Okay, and the problem with 1,3-beta-D-glucan is that it is notorious for false positives. Okay, and I think that is really one of the major issues out there, is that when you get a positive back, you're not quite sure what to do with it. I would really argue that galactomannan is the gold standard for diagnosis of invasive aspergillosis at this point. The brand new European guidelines for the management of invasive aspergillosis were just published on the ECMID site earlier, I think a couple of weeks ago, and again, really come down very heavily in favor of using galactomannan. I think for this audience, it's important to really recognize that patients who are on mold active therapy do not get a serum galactomannan. Mold active therapy suppresses that result massively, and a negative tells you nothing. The Europeans go so far in the new guidelines as to give this a D recommendation, which is basically do not do. Okay, that's what the D stands for, do not do, okay? And so really watch serum galactomannans in people on mold active therapy because they're hugely misleading. The galactomannan out of a BAL while someone's on mold active therapy remains, I think, a very useful diagnostic tool and is highly recommended in a lot of the guidelines. So we've talked a little bit about epidemiology, we've talked a little bit about diagnosis. Let's get into the drug therapy. For those of you that have been living in a cave since 2002, one, I pity you because there have been 17 bazillion new oncology drugs come to market since 2002, but AMPHO is dead. AMPHO as primary therapy for invasive aspergillosis is dead. Voriconazole is the gold standard across every guideline you will run across, and when you go back and look at this literature, voriconazole took amphotericin B out and kicked it around the block. End of discussion, okay? And when you look at this, you can see, and this, guys, this was a tough study. I think a lot of times we forget how many proven cases were actually in this study. I mean, this was not a lightweight study, and Vori went out and kicked AMPHO around the block. The new kid on the block, isavuconazole, get that, right? Isavuconazole. Who permitted that? Right? How did that get through the FDA? I mean, do you even need a brand name with that as your generic name? I still am blown away by this. But this was isavuconazole head-to-head with voriconazole, and basically what you saw here was this. Can you distinguish between those two Kaplan-Meier curves? Because I sure can't. Okay, and so I think as far as clinical endpoints go, there was no difference here. But, again, when you look at this, you saw as far as clinical events went, there was really no difference. But check out the drug-related adverse events. And I think this is where things get a little bit interesting. For those of us who've been playing with voriconazole since 2002, a lot of us have really come to hate voriconazole since 2002. Nonlinear PK, crazy drug interactions, huge interpatient variability. It's a tough drug to deal with. And by the way, all that skin cancer stuff that's lurking in the derm literature is absolutely no fun. You've got to do therapeutic drug monitoring on it, which, do you guys have fun too saying therapeutic drug monitoring to your docs and watch them get nauseated? The way to run a physician out of a room is to tell them they have to do therapeutic drug monitoring. They will just run screaming from the room. And so the docs hate it. It's tricky. The nurses draw it wrong. There's all kinds of fun stuff. And isavuconazole looks a little bit more predictable from a PK standpoint. So I think it's a better tolerated, better PK drug, but unfortunately remains much more wallet toxic toxic than voriconazole at this point in time. Trying to get this stuff approved through insurance is no small feat. How many of you saw Gronk's YouTube video for whether or not you should eat Tide laundry pods? You saw it. Excellent. So you will recognize this response. No, 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 no to this slide. Okay? Echinocandins for invasive aspergillosis as monotherapy. If you don't like the patient, go for it. Okay? If you like the patient and want them to get better, I would strongly discourage it. Basically, I think at this point in time, echinocandins for invasive aspergillosis are when you're painted into a deep, dark corner, when you cannot give them an azole, you cannot give them ampho, maybe, but I think these drugs, as will be fought about later, are potentially really best in combination at this point in time. The other thing to point out here, too, is that we've got new drugs for the mucorales out there. We've actually got Posa and ISA out there instead of just the ampho. And this is something you're never supposed to do. Take data from multiple studies and try to line up response rates. Horrible, horrible idea, which is why we did it, right? It's a debate. We want to start a fight. This is a great way to do it. So the long story short, ISA has the FDA indication. It's in like 37 patients compared to a historical control against ampho. Posa has a ton of historical data, or has a ton of retrospective data, but all of the mucor data there is from people who are massively treated with ampho and massively surgerized. The FDA looked at that data and said, what'd your drug do? All those guys got a ton of ampho and got surgerized. I have no idea what Posaconazole actually did in this situation. That was the response of the FDA when they looked at that data. So long story short, if you like the patient, you still start with ampho. I think almost every expert out there would agree, and maybe not. Maybe we'll have a big fight on this one too. But I think that most folks would still start with ampho, lots and lots of lipid ampho until they can't lipid ampho no mo. And then basically you move over to one of these new generation azoles. Again, I would love to see my brethren duke it out as to which one of these, if either, are better from Eucor. My money says no difference, but we'll see what the boys do with this one. So, summary, treating molds. If I walk up behind you at the breakout here and I say aspergillus, you have less than 2 seconds to get the word voriconazole out of your mouth, okay? Now, I would also argue that given ISA's current data, that was a head-to-head trial, phase 3, randomized, double-blinded, boom, boom, boom. Head-to-head, ISA-Vori, no difference. ISA better tolerated. The new European guidelines have ISA and Vori on level footing. Okay, the IDSA 2016, I've been told the reason they're not on level footing was that all of the ISA data wasn't in when the guideline data cutoff occurred. Okay, so I really expect in the next set of guidelines to see ISA and Vori on basically the same footing. We've talked about mucor for fusarium, holy water, prayer, and whatever antifungal you want to throw. Knock yourself out, okay? But realize these things are almost always resistant. Scedosporium apiospermum, you'll also hear this called Pseudaloscheria boydii. Vori remains the drug of choice. If you have Scedosporium prolificans, think of this as basically fusarium in disguise and find a priest, because basically these are resistant to just about everything we have out there. So, before I hand it over for the, now you two gloving up? I don't see gloves yet. Put the gloves on. So, patient case, okay? We're going to walk through a little bit of case here. And this is a very wordy case, so I'm not going to read it, but I'll hit some of the high points. This dude is one of your peeps, okay? This is how the case starts. He's had 6 days of high fevers, and a high-res chest CT is performed. My question is, what happened there? Was the entire hemonc department in the CT scanner? I mean, if you have high fevers for like, 24 hours at our place, you're getting a high-res chest CT. So anyway, but he was on Prophy with Vori, okay, so he's on Prophy with Vori. BAL is performed, cultures are all negative. Aspergillus GM, galactomannan, is negative. Now the question you should ask me right there is that a serum? Because if that's a serum GM, it's useless. If that's a BAL GAM, okay, now I'm a little more interested. And the Fungitel, please, whatever. It's negative, that's nice. That's all that really tells you. He's satting well on room air, and his white count has been slowly increasing. So the question becomes, using those aforementioned EORTC criteria that I talked about, what does this guy have? And we will now click it over, I hope, to the, there we go, to audience response. Come on. They told me a green box would appear in the upper right corner, and it is just not doing that. Click repoll. Oh. All right. We got it? Because I'm not seeing a repoll. You come over here and show me, Bernie. Oh, it's green. It's green there. Sweet. Answer questions. It's not green on my screen, but it's green on that screen. All right, and we've got... Now there is more, okay, we're up to 25. There's more than 25 of you in this room, and there's I have no idea as an option. Okay, so you're more than free to take that one if you don't know. All right, we are up to 37, 39. Come on, one more. There we go. All right, let's cut it off. Oh, come on. This thing thoroughly aggravates me. I'm going to give it to you guys. Oh, here we go. It showed it there. So a lot of you went with probable. Remember that that's only possible fungal infection, because go back and look at those criteria. Basically, everything on this guy is negative except for he has risk factors. And so that's what makes this guy a possible and not a probable here. And I'm going to get out of the way because you can feel the tension building as these two circulate over here.
Is this mic on? Check 1, 2, check, 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 check. There we go. I was told I was not allowed to stand near Bernard. So now that Jim has properly educated you guys, I think we've fulfilled our HOPA requirement. Now Bernie and I, this gives us the next, oops, can't stand over here, 50 minutes to just make fun of each other. So I want to set the stage. You have Bad Cop over here, that's Bernard. And at the University of Michigan, we're a team, except Bernie always gets me in trouble for the shit that he does at U of M. He is mean. He critically appraises literature. He's always the guy to say, no, you can't do that. And no, what, you don't know the data on this? Well, no, too bad, we're not doing this. So that's why Bernie got the name Bad Cop. And the guy has been preparing for this role of HOPA for the last year. So much so that he's grown an ugly ass beard so that he looks uglier and meaner. And if you guys don't believe me, look through the faculty pictures on your HOPA app, pull it up, and look what Bernie looks like a year ago today. He looks like a child. And you guys are laughing. I have to travel with this guy. Imagine getting through TSA pre-check with a guy that's on the no-fly list because he looks like a terrorist. It is particularly challenging. So anyways, I'm good cop. I'm holding a baby. I'm so nice. All right, so the first debate that we're going to be debating about is, should you use Posaconazole, prophylaxis, or can you use something else? All I have for you, Bernie, are 3 words: overall survival benefit. Let's take a look at the past 50 years. What have we had as a drug therapy that has improved overall survival? Well, we fiddled around with daunorubicin dosing. We showed that 90 is better than 45, but that's a subgroup analysis. Those are essentially just patients under the age of 60, maybe 65, okay? And that was just the same old drug that we use differently. What about new FDA approvals? Midostaurin, that overall survival benefit is modest at best. It is not that impressive at all, okay? But it's the only FLT3 inhibitor, so we'll use it. Now, that's also a subgroup. That's only 30% of patients that have FLT3 positive disease. Small subgroup. Liposomal daunorubicin or CPX, another modest improvement at best. Another subgroup analysis, secondary AML. Hello, how are you? Lots of old residents here. Gemtuzumab, I hope to God you guys are not using gemtuzumab. There is no overall survival benefit. It is a complete waste of money, okay? So no overall survival benefits with any of our new chemotherapies. Well, guess what, Bernard? Posaconazole has improved overall survival. It is the only drug in the last 50 years, and it's not even the blue-blee-blahs that Jim was talking about. It is actually his drug. Jim has improved overall survival in his realm. So thank you, Jim. Sorry, Bernard. So in 2007, New England Journal of Medicine, Cornley, there was a pivotal clinical trial, phase 3, that randomized patients to Posa or fluconazole. Okay, these are patients getting intensive chemotherapy for AML or MDS. Primary outcome was proven or probable IFIs. You were 4 times as likely to get an invasive fungal infection if you were treated with fluconazole or itraconazole. 4 times. And this led to your patients dying faster and dying more with fluconazole compared to posaconazole. Okay? So that means that for every 14 patients that you treat with Posa, you're saving 1 life. Bernie, should I mic drop now or should I continue? All right, so what data do you have? Isavuconazole? Nothing. There's no prophy studies. What about toxicity in voriconazole? Like Jim elegantly already discussed, what happened? Oh, your patients are going to hallucinate, Bernard. You're going to get skin toxicities, cancers. Your LFTs are going to go nuts, and everybody on your whole entire team is going to freak out because the LFTs are now 100 or 200, right? Okay? Visual disorders, they all get the auras. Those little old ladies hate that, okay? So, safety, efficacy, azoles, they're out. The only drug that you should be using because of an FDA approval and an indication is posaconazole. What about your echinocandins? Jim already showed you that echinocandins are not great drugs for aspergillus, but you want to prophy them? So MD Anderson has shown that we should not be doing this. Why? Because again, another survival curve here, Bernie. You're killing your patients faster if you give them echinocandin prophylaxis. So tell me, Bernie, riddle me this. How are you going to argue me that echinocandins are okay? And figure it out. You want the clicker?
Yeah,
all right, you need a microphone too.
Can we mic me up? All right. So, Anthony, let me ask you a question. When do these patients get mold infections? First 30 days, 60 days?
The first 30 days is your primary place because that's when you're neutropenic. And then usually, after you go through 3 and 7 or whatever you guys are given, 30 days, 21 days, you're starting to pop up your neutrophils. So that period, Bernie.
Okay, and we can look at this curve here. When did people use the echinocandins in this study? The first 30 to 60 days. They were preferentially used at the time when these patients were most at risk for invasive mold infections. In contrast, your anti-aspergillus azoles over there in the purple, they were used up to day 120 post-initiation of therapy. So they were used during the period where these patients aren't getting mold infections. And your outcome here was IFIs per prophylaxis days. So you're completely cheating here.
So you're telling me you don't believe MD Anderson's data?
No, I don't. You know.
Guys, this is MD Anderson.
You trained there. You know about the MD Anderson effect. Things look better when they come from MD Anderson, right? That's the MD Anderson effect. We're not making fun of MD Anderson.
No, we're not. Sorry, guys.
So bottom line here, the outcome measure is flawed. If you're looking at IFIs per prophylaxis days, and your denominator in the echinocandin group is only that at-risk period, and your anti-aspergillus azoles are being used for 120 days post-therapy, those patients are going to be, it's a selection bias here. And that's why the patients on echinocandins look worse. And if you actually look at the data, if you want to be dogmatic about this, fluconazole in the blue actually has the lowest IFI rate for per prophylaxis days. So you want to use fluconazole for your patients then? It's the best per this study, right? No answer. Okay. And I know you have no answer because you and I published a rebuttal to this paper 3 years ago. So I know you don't believe in this study. So in the certain clinical setting, echinocandins are okay for prophylaxis. So let's use our brains here. What agents could we use for prophylaxis? We have to think about what's the spectrum of activity of these agents. So compared to posaconazole, which we're going to consider our gold standard here, what other agents have similar spectrum? Well, Vori and ISA, as Jim already went over, have very similar spectrum of activity, except for the fact that Vori doesn't cover mucorales. How common are mucor infections in your patients, Anthony?
They're not very common at all. I would say most of the time when you see mucor, it's you have a patient that's been neutropenic for 30 plus days. They're a multiply refractory patient.
Okay, so not everybody's going to get a mucor infection if they're on voriconazole.
No.
Okay, let's move on. Now you said there's no data for other agents. There's no data for isavuconazole. That's fine. But is there data for voriconazole? This question always comes up. And yeah, I agree, we don't have prospective randomized trial data, but we do have a retrospective cohort study that MD Anderson also did, comparing patients on voriconazole prophylaxis with those on posaconazole prophylaxis. And their primary outcome here was what was the rate of proven or probable IFIs in these patients. What did they find? There was no significant difference in proven or probable IFIs in these patients. There was a slightly higher rate of symptomatic adverse events in the voriconazole group, which were 3 patients had a little bit of tummy upset, 1 patient had a rash, and I think 1 patient hallucinated. That was it. And those are easily mitigated by therapeutic drug monitoring. Importantly, the changes in terms of discontinuation due to side effects, no different between the 2 groups, and all-cause mortality was no different between the 2 groups. So where's your mortality benefit now? Patients in the Vori group actually did better. Let's actually break down this prospective trial that Anthony's really hanging his hat on here. Jim talked about the diagnostic criteria and the difference between proven, probable, and possible IFIs. We saw that posaconazole reduced the incidence of proven and probable IFIs, but we already said that posaconazole in itself reduces the sensitivity of your galactomannan. So to have a probable IFI, you have to have a positive galactomannan, that mycologic criteria, plus the host factor, plus the clinical factor. So is there any difference in proven IFIs between those patients? There's not. There's absolutely no difference, it's not working, in proven IFIs between posaconazole and fluanitra. So really, the difference here between the 2 groups was in reducing the sensitivity of your assay, which we know sucks. So does posaconazole truly prevent IFIs in this study? There's no difference in proven IFIs. Let's actually take a look at all the different species that were found in this study. So this is a cohort of 600 patients. And in this entire cohort of patients, the majority of these infections were aspergillus. Jim already drilled it in your head that voriconazole should be the first thing you think about when you see a patient with aspergillus. So we know it could potentially work in these cases. These Canada species, there's not going to be any difference between Vori and Posa. Pneumocystis or PCPs on here, none of these agents are going to work for that. Scedosporium, we also said that's a terrible bug with very poor data. And 1 mucor case out of 600 patients. That's a rate of breakthrough mucor infections of 0.1%. So because of the rarity of mucor infections, in these patients, alternative azoles like Vori are appropriate in the right clinical setting. The last thing we have to consider, because we've determined that safety and cost, or safety and efficacy are equal, is cost. So let's take a hypothetical healthcare system here. Let's call it Perini University, Parasinati Marini. Let's call it Perini University. Let's say we purchase posaconazole at $200 a day, and Vori costs us about 1/10 of that. Let's say we treat patients for 30 days in induction with prophylaxis, and then give them 4 consolidation cycles. That's up to 150 days of prophylaxis with these agents. Based on those costs and treating about 100 patients per year, you're talking about $2.5 million in excess costs using posaconazole instead of voriconazole. The cost is just not justified.
Jim, I blame you for this one. This is your fault. These are your drugs. Why are they so expensive?
Well, my drugs are so expensive? You really want to go down that path? You really want to go down that path? You can shake the couch cushions on the ONC unit and come up with $196 a day. Please.
All right, guys, just in the sake to shut Bernie up because he just keeps talking, what do you actually do in clinical practice? I think as pharmacists, we have to go beyond just what does the package insert say? What does the FDA label say? What do the actual big phase clinical trials say? And sometimes you have to look at the totality of science. And I will admit that Bernie did a very good job, a very elegant job, I might say, showing you that it really makes sense to be able to use other drugs from a cost, from a safety endpoint, and an efficacy endpoint. However, every patient is different. You can't treat every single patient with voriconazole as your prophy, okay? So what we'll do in our practice is first-line induction, 3 and 7, G-clam, whatever you guys are given. Voriconazole, because that patient is likely going into remission. Their duration of neutropenia is probably going to be around 21 days. They're not at high risk for mucor. So voriconazole for those patients. However, if you have a primary induction failure, you have a multiply relapsed refractory patient, that's when Bernie and I are pulling out the posaconazole and the isavuconazole, and we're willing to spend a little bit more money. The other patients are, what if you have a patient on a FLT3 inhibitor, and you have lots of drug interactions. Maybe ISA might be okay, but sometimes in clinical trials you're not even allowed to do that, and you have to back off and use just your echinocandin. And I think that is okay, especially in the front line. We get a little bit weary when patients are multiply refractory using echinocandins, but you have to be very, very vigilant in those patients. So I'll give you 1 point for now, Bernard.
All right,
let's
1 to
move
0.
on.
Okay. Now we're going to talk about therapeutic drug monitoring, which Jim already said is going to make everybody nauseous in this room. Anthony's going to try to swindle you into thinking you should spend more and more and more money doing therapeutic drug monitoring in these patients, waste a lot of your time checking levels in all of these patients. And I'm going to take the rational approach that maybe it's not a cost-effective approach. So when should we do therapeutic drug monitoring? Well, you all know this. It's for drugs that have a narrow therapeutic index. So if we're out of the range, if we're super therapeutic, we can expect excess toxicity. When our levels are too low, we can expect breakthrough fungal infections. So does this hold true with Posaconazole, especially Posaconazole suspension? Does anybody see increased toxicity when your POSA levels are 2,000, 3,000? No. Anthony, do you see a lot of toxicity? Do these patients' livers melt when their POSA levels are 3,000?
No comment.
No comment, okay. That's a very interesting question for him. So, super therapeutic levels probably aren't an issue with Posaconazole. What about subtherapeutic levels? Well, the Australians did a big cohort study in a number of different patients getting Posaconazole trough concentrations, and they correlated them with breakthrough fungal infections. What they found was that as long as your Posaconazole levels were greater than 500, none of these patients had breakthrough mold infections. In addition, if we take the studies that led to the approval of Posaconazole for prophylaxis, the Cornley and Ullman studies published in New England Journal, and we take those patients' POSA levels and we divide them into 4 different quartiles, we see that the quartile on the far left, that's the lowest Posaconazole levels in this study, their rate of breakthrough mold infections was somewhere in the range of 40-45%. Very high rate. In contrast, patients in the 2nd, 3rd, 4th quartile had a rate of breakthrough of about 25% rate of clinical failure. So we see that there's differences in terms of the rate of breakthrough infections when you have lower Posaconazole concentrations, but it's really at a level of less than 500 to 700. Now, when we put these slides together, Anthony said, this one's not fair. I'm just going to destroy you in this section because it's a no-brainer to do therapeutic drug monitoring with Posa. But he's a little older than me. You can see that his beard is graying a little, which is why he doesn't grow it out like I do. And he forgets that there's been a Posaconazole tablet that's been approved, and pretty much everybody's using nowadays. Now, the Posaconazole tablet leads to levels in the 1,000 to 2,000 range. You rarely have patients that are less than 500 to 700. And, hold on. In that study that showed a survival benefit, the median POSA levels were 583. That's all you need for a survival benefit.
That's completely untrue, Bernie. We don't get perfect concentration. Yeah, throw me this thing. We don't get perfect concentrations in real-world patients. Sure, in clinical trial patients that are glorified patients, right, you get levels of 1900, but I see a number of investigators in this room that have looked at this question of what, in real-life patients, do you get serum concentrations of Posaconazole? Here's one of our experiences. We actually found that 20% of patients, even though Bernie's saying 100% of patients are hitting above 700, 20% of real-world patients, because they have mucositis, because they have tremendous amount of diarrhea, 20% of your patients are going to be at risk for clinical failures. And again, this isn't just our evidence. Jim, didn't you publish on this too? Yeah, thank you very much. And there have been several other investigators in here. Laura Tang is one of them. This is her data here. Shauna Kraft, I noticed, is in the back as well. This is her data. And I think Beth might be here. I kind of saw her walking in. So voriconazole, the inter- and intra-patient variability is 100-fold, meaning that you could give a patient 200 BID, 300 BID of voriconazole and get a level of 0 in one patient. And then another patient, you can get a level of 14. And why is that important? Well, because we know that we want patients in this range of above 1 so that we have therapeutic efficacy. Otherwise, they're going to have clinical failures again. Or if you have a patient above 5.5, those patients are going to be at higher risk for the neurotoxicity. So TDM is very important for us as pharmacists to say, hey, I want to stay between this range. I have a tremendous amount of variability. So I would definitely recommend TDM for VORI, absolutely, and for Posaconazole. You can take less of a systematic approach and go more by a risk factor approach where you look at, in our study, we did a multivariate logistic regression. We found that diarrhea was the biggest predictor. So if you have a patient with a lot of diarrhea, throw off a level. I guarantee you it's going to be low. And if it's not low, great. That was one of the very little that won't have a low level. Now, Isavuconazole, when you look at the clinical trial, their variability was actually very high too. Their median was 3,900, but you had patients that had levels all the way down to 450, all the way up to 8,000. We don't know what we're supposed to be hitting for Isavuconazole. I guess in our practice, we're kind of like, well, try to hit closest to the median. Whether that's the right answer or not, that's what we're doing in our clinical practice. So I think this was pretty clear, Bernie.
Yeah, I lost this one. I'll give it to you. So it's pretty clear TDM does have a role. Real-life patients.
To a room full of pharmacists, essentially saying that therapeutic drug monitoring.
Hey, we had to build some debates that you would win just because they're easy. So, I mean, sometimes you have to throw them a bone. Here, give me the thing.
Try to catch.
Got it. I'm a hockey player. I don't catch well. All right, so let's move on. This is going to be really controversial. I think Jim will like this discussion. So this is about double antifungal coverage and whether combination therapy truly has a role in these patients. So we love Taylor Swift. We're the Bad Blood Research Consortium, so we have a lot of Taylor Swift GIFs or GIFs or whatever in our studies. Anyway.
They're called GIFs, Bernie.
It's a debate, too. Doesn't matter. Anyway, there are a number of in vitro combination studies looking at combinations of antifungals in vitro. And the problem with this data is it's messy. You can find just as many studies that show that two antifungals in vitro are synergistic and beneficial together as you can find studies showing that same exact combination is antagonistic, and you're potentially doing your patients harm by combining these. Look at all these studies I'm finding. They're all over the map. You can find these in vitro studies. And so it's irresponsible to do this to patients, to combine antifungals when we don't know what the effect will be in terms of whether it's beneficial or not. We don't just take two chemotherapies that haven't ever been studied together because in vitro there might be one study that shows synergy and pair them together in patients without any clinical data.
Yeah, but Bernie, go to the next slide. It makes total sense, right? Just like with why you use ampicillin and vancomycin, right? Your penicillin for staph. I don't know any ID stuff.
We don't let you oncology pharmacists near the antibiotics.
All right. Point proven. However, when you look at the mechanism, right, of amphotericin, your azoles are big, huge structures. They're not going to penetrate through that cell membrane at all. So what you do is you just start breaking down the cell membrane with amphotericin. You make it nice and leaky so that big azole can just come inside the cell wall and then work on linosterol demethylase inside the cell. So it makes total sense for Bernie. So scientifically, Jim, do you disagree?
A little bit. Yeah. I mean, I for once, I have to agree with Bernie, and it's largely because I'm jealous of your hair. But,
What about my hair?
Bernie, I love your hair too, but the beard does scare me a little bit. I must say.
That and the rapist glasses.
But I think that to Bernie's point about a lot of that ampho-ergosterol stuff is done very much in vitro, and I think the animal models are much cleaner. And I think that's one of the things we have to be very careful about is the in vitro stuff. I really kind of agree with the point. You can make it stand up and dance however you want. The animal stuff, and I don't really like the ampho-azole combination for molds because I do agree that some of the animals are very not consistent. Now, I'm waiting for the echinocandin combination discussion, and I'll throw it to you two to duke that combination out.
All right, so echinocandins, I already elegantly showed you the pharmacology, and then so here, you already just stole my whole entire argument.
That was my goal.
In a neutropenic rabbit model, we see in yellow voriconazole. It kills aspergillus pretty good, right? However, when you add an echinocandin on top of that, you get synergy. Keep going, Bertie.
Okay.
So
Do you want me to? I'll take over here because you're going on and on about these bunny models, these rabbits. You're obsessed with these bunny rabbits. I have a 5 and a 10-year-old daughter. They like bunny rabbits. You should like clinical data more than you like animal models. So let's actually look at some clinical data. Does this hold up in practice, this combination of azoles and echinocannins for mold infections? So Kieran Marr finally published this study in 2015 after a much-awaited long treatment period, looking at the combination of anigilafungin and voriconazole versus voriconazole alone for the treatment of proven or probable invasive aspergillosis. And their primary outcome here was all-cause mortality at 6 weeks, which is the outcome that most correlates with IFI-related mortality in these patients. And disappointingly, there was no difference in survival between combination therapy and monotherapy. Combination therapy offered no advantage to these patients. In addition, if you look at global response rates, so you'd expect if we give 2 antifungal agents instead of 1, it should work better, right? We should see higher response rates. Maybe it doesn't improve survival, but maybe patients have better responses. In fact, that's not true. Global response rates were actually better in the monotherapy arm than in the combination therapy arm.
So advance the slide, Bernie. So why? Why were patients having higher responses in the monotherapy arm versus the combination? Well, 40% of the patients had to drop out because they could not get evaluated for a response. So let's look at why they didn't get evaluated. Well, in the monotherapy arm, they couldn't get evaluated because they couldn't get another CT scan. Why? Because they were dead. So how can you assess response when you're dead? Whereas the combination arm, they couldn't assess response because their investigator said, well, you know, you're doing so well clinically that I don't need to get another CT scan. And so that's why the response rates are lower in that clinical trial. So Bernie, what would you rather be? Would you rather be the arm that has a higher response rate but dead? Or would you rather be the combination arm that had, I guess, the lower, artificially lower, but still alive? And actually go back to the last slide, and this cumulative survival, you see a clear separation in an underpowered study with an almost statistically significant p-value.
Almost statistically significant? What the hell does that even mean?
If you had those 40% of patients...
I almost improved survival, but I didn't.
can guarantee you that would have been statistically significant. Let's move on to a very sensitive group, a subgroup of patients that had a galactomannan, so a patient that had a higher disease burden. You see that we reduced mortality by 50% with the combination azole and echinocandin. And Bernie, there you go. There's a statistically significant p-value there for you. Fine. Carry on. All right, so we talked about aspergillus, and I think Jim wants us. Is this the piece you really wanted to start?
Actually, I want to back it up, and I want to
back it up
right there. And go back one more for me, Bernie. So that I have to say, I think those are some of the most beautifully drawn Kaplan-Meier curves I've ever seen.
Thank you.
But after that,
by hand.
do both of you like your mother?
I love my mom.
You love your
my
mom?
mom. Yeah,
Bernie, you get along with mom?
Yep, very well.
What are you giving mom with a p-value of 0.087 and a 10% difference in survival?
I'm giving my mom double therapy with a p-value of 1.
Okay.
I don't even care.
Okay.
Because why?
Bernie,
because
what are you doing here, Bernie?
So I'm also giving my mom combination therapy.
Oh, okay.
But my stewardship group is telling me to stop it. So I'm not able to give my mom combination therapy. Because I'm wasting money.
That's on you, Jim. That's your fault.
It's your
That's
drugs.
why my mom didn't get combination therapy.
It's you guys' drugs that created these patients. Just saying. Just saying.
All right, so that's aspergillus. We keep going back and forth. We'll give you a true thought of what we would do in clinical practice in a second. This is clinical data or in vitro data or neutropenic mice models. You see placebo versus amphotericin, not really much difference in kill. However, when you combine it with an echinocandin, that an echinocandin has no activity on mucor at all, but when you combine it, you actually get synergy. Why do you get synergy? Again, it's going back to the science. So, echinocandins bind to glucan synthetase, right? So it doesn't kill the mucor, but what it does is it makes the mucor rearrange its cell wall to expose this glucan so that your phagocytes can then cause an immunologic response and then synergize and then synergize with the amphotericin. And that's why you get synergy. And here's your clinical data, Bernie. 100% survival if you give an echinocandin with amphotericin for Mucor. And this is the study that has been quoted in IDSA guidelines, or not IDSA, European guidelines. It is what experts across the country use to justify using combination echinocandin, and it's what our institution, ID practitioners, also justify in order to give echinocandins, even though there's no activity, with amphotericin. Because 100% survival, Bernard.
I'm speechless right now. Jim, do you believe 100% success rate in mucormycosis?
It is.
Does that strike you as a red flag?
It is surprisingly good, shall we say?
Okay. Anthony, does that strike you as surprising at 100% response rate?
The synergy is profound.
That's very profound. That's very profound. I'd like to point out here that there were massive imbalances in this not prospective randomized controlled trial. This was a crappy retrospective study that we cannot draw any conclusions from. First of all, if you look at just liposomal amphotericin B in this study, which is what we use nowadays, the success rate was also 100%. So no different than your combination therapy. Most of the patients in the monotherapy group who failed were receiving deoxycholate amphotericin B. They had toxicity, and so they failed. Their kidneys failed, they went into renal failure, they were considered clinical failures. Pretty simple, right? If you look at this study and you look at what were the risk factors of patients failing, there was a significant imbalance between the two groups. So pretty much every risk factor you can think of patients doing poorly in this study was found almost 3 times more commonly in patients receiving monotherapy. There were 3 times as many patients with malignancy in the monotherapy arm. There were double the amount of patients on magic brew or corticosteroids in the monotherapy arm. And all of the transplant patients and all of the neutropenic patients were all in the monotherapy arm. So it's a completely skewed study that we can't rely on to say we should give patients amphotericin B and echinocandins as first-line combination therapy for patients with Mucor. It's nonsensical. And I'll go back to this picture that Anthony's elegantly drawn here. Actually, I think he stole this one. If you look at how these agents work, because the next question is going to be, can I combine amphotericin B with azoles, right? Because intrinsically they both have activity. So that's the natural combination to think about. But these are potentially antagonistic in vitro, because if you're inhibiting the ergosterol synthesis pathway, if you're inhibiting lanosterol demethylase, and you're preventing the formation of ergosterol with posaconazole and isavuconazole, you're preventing that mold from having binding sites for amphotericin B. So instead of having activity, it's just going to your patient's kidneys and causing nephrotoxicity. And there are a number of models in aspergillus and in mucormycosis showing antagonism of combinations of amphotericin and azoles in these patients.
Well, going back to Jim's point, he already sold the argument for me, is that the in vitro data is not predictable whatsoever. So we can go back and forth as much as we want on synergy antagonism. Let's drop that entire argument. There are 3 reasons why you would want to use combination therapy. One is for synergy. Okay, great, it's gone. No argument. The second is to prevent resistance. We're probably not doing that. We're also not causing resistance, so let's get rid of that argument. The third argument, which I think is the most important, is empiric coverage, larger empiric coverage. So you have a patient that Jim already discussed earlier, fusarium or Mucor. We have no idea what to expect. Like he said, we're getting the priest, we're getting the holy water out because we don't have drugs that we know of that are going to be able to have activity. So what we do in the empiric setting, just like we do in the ICU setting with antibiotics, what do? You don't just start with one antibiotic. They're usually on 2 or 3. You're loading them with Tober or amikacin plus the vancomycin, right? Why? Because you're trying to broaden that coverage. So why doesn't that thought process, Bernie, apply also to a fungal infection that has nearly 100% mortality? Here's a case that we had of fusarium, a disseminated fusarium all over this patient's body, in their liver, in their brain. And so the drug of choice, voriconazole. So if we would have done just single agent voriconazole, go on the next slide, Bernie. What are the susceptibilities? Both resistant to isavuconazole, posaconazole, and voriconazole. The only thing that worked would have been amphotericin B. So again, this could have flipped around and been resistant to ampho and only been susceptible to vori. So again, it's to broaden that coverage until we know exactly what bug we're dealing with.
Okay, I'll give you this round. You won. All right. There is a role for combination therapy, but it's in a select group of patients. So when we think about treating Aspergillus infections, if you have a patient with a couple of small nodules who you expect to recover their counts very soon, maybe in the next week or so, you can get away with monotherapy in those patients. But if you have a patient who's critically ill, let's say they're in the unit with, they're ventilated, they have massive fungal disease burden, they've got huge Goombas in their lungs, maybe they're multiply relapse refractory and you don't expect them to ever recover their counts. Those patients need combination antifungal therapy because they're at the highest risk of having a mortality event with Aspergillus. That's our practice. I know practices differ across the country. Jim, what do you do for Aspergillus?
So for us, when we start to get into situations where we have positive galactomanins on BALs and we have CT findings that are concerning, we are typically going straight to vori plus the echinocandin. If it's just, there might be a little something there on CT, then it tends to just be the azole monotherapy.
That mirrors our practice perfectly.
Sounds like I get a point for
that.
that.
You get a point there.
Argument.
All right, there's still one more debate left. And let's talk about the non-Aspergillus molds here too. And I'll echo what Anthony stated. The point here is not to achieve synergy or to achieve the best combination. It's really to have the best shotgun approach for your patient who's critically ill and maybe growing mucormycosis or fusarium until you get susceptibilities back. And let's say you are treating mucor, you can treat them with amphotericin for as long as they'll tolerate it, but it's nice to get that azole on board quickly so that you can get it up to therapeutic concentrations, so when your patient goes into renal failure, you can switch nicely to posaconazole or isavuconazole in those patients.
So Bernie, I love the beard, but I have to disagree with you on that a little bit. Or do we still have to be doing that for the mucor in an era where we have posaconazole tablets and posaconazole IV and isavuconazole where we're getting them up fairly quickly with loads? Because I do still worry about some of the animal data with the polines and the azoles bumping into each other with regards to the mucorales.
I think it's timing related. So in a lot of those models, if you start the azole first is when you get the antagonism.
Right, because you deplete the ergosterol.
Right. So usually what we do is we start them on the amphotericin for at least a week, let's say. And then you're going to have another week, even if you load that patient until you get up to therapeutic concentrations, even with oral therapy, or you're going to wait probably 5 days until you have that patient up to steady state. So that's a full 14 days of probably amphotericin by itself before we then transition to the anti-mucor azoles in those patients. And most patients in our practice haven't been tolerating it for that long. More than 14 days is where we start to run into trouble. What do you think?
It's a world debate, right? Nobody knows truly what the best approach for these patients. Why? Because we have no clinical data at all.
Yeah.
And so what it comes down to is logistics. What makes most sense for you, for your patient, right? And a lot of times it is the logistics of finding coverage for POSA or ISA. It's figuring out if you can actually get, because what if this is a GVH patient? That patient's probably not hitting concentrations of 1,000. Who knows if 1,000's even enough for mucor? We have no idea. What I want to see is I want to see the absolute highest posaconazole, isavuconazole concentrations known to mankind when I'm trying to treat mucor or fusarium.
Agreed.
But yeah, it just comes down to logistics.
All right.
The last piece is probably the most challenging piece of controversy, and it's a real-life dilemma that we all have. Is go to the next slide. You have a patient that is on posaconazole, and the first thing is obviously you can check TDM. Okay, if their levels are low, great. You can just increase their posa or switch to vori and make sure that you're treating with vori at proper concentrations. However, in clinical practice, this always comes up. You have a patient that their posa is a level of 2,000. And this is another reason why we do TDM, is because when you're faced with that fever for 3-4 days, You can then go look back at your POSA level and you're like, oh, they have a POSA level of 3,000. That totally changes the differential diagnosis. So what would you guys do in this setting? You have a patient on Posaconazole prophylaxis, and now they're fevering for 4 days. You CT scan them and you see a nodule on CT. Would you A, give amphotericin, B, isavuconazole? Is this, yeah, great. Oh, people are already answering. Fantastic. C, ampho plus mica, or D, voriconazole. And I think the little girl has it right because we have no idea what the proper answer is for this patient.
Should I click? Yeah. Let's see.
Let's see what we got here. Wow, okay. So we got some that are switching to ampho. I think that's very reasonable. And then some that are, despite us showing how terrible that data is, you're still doing amphotericin plus micafungin. And some are doing a lateral switch to voriconazole. So we're going to go through every one of these to see what makes the most sense. All right. So when that happens, there's a couple thoughts that are going through my mind. And the first thought, when you have a level of 3,000, you have the wrong diagnosis. A patient fevering for 4 days plus a CT finding does not equal aspergillus. However, for the past 15 years as hematologists, we are always kind of ingrained that fever plus CT findings equals aspergillus until proven otherwise. I think that needs to change because we are so much better at treating aspergillus. It's not, the 1990s when we didn't have effective therapy. I think we have more room to be wrong. However, most of the time, I would say in our practice, when we have a patient fevering for 4 days, and you get a CT finding, a lot of times it's not aspergillus at all. It's a new bacterial infection, or it's nothing at all. Or it was there for the entire period and you just CT'd them and found some sort of finding that you wanted to go after. So our approach usually in a clinically stable patient is just chill for 5. Just let the patient fever. If they're clinically stable, they're not requiring oxygen or anything, just hold out. I guarantee you that their fever curve will start to break. And instead of spiking, they're going to spike and get smaller and spike, and then eventually their fever is going to go away with you doing absolutely nothing. And that's probably the most common scenario that we see on our service. However, do we do things in clinical practice differently? Yes. We start adding and adding and adding, and ID loves us when we start doing this. But that's kind of irrational from my perspective. Because you're essentially saying that you have an azole-resistant mold. So let's go through the next couple slides. Skip this stuff. You guys can learn about all azole resistance and the mechanisms, and skip this one too. So does azole resistance occur in the United States? Well, there have been multiple studies that have sent thousands of samples to San Antonio, and we have found that we have a less than 5% chance of having an azole-resistant mold in the United States. And I don't believe there's any in Colorado. So this slide here. What does azole resistance even mean for aspergillus? So we made up some sort of breakpoint of 1, and I guess anybody that has an MIC greater than 1, we're calling that resistance. To me, what resistance is resistance equals clinical failure, okay? Now, when you look at all these patients that had MICs greater than 1, the only patient that had a clinical failure was the patient with the MIC of 32. So I would argue that, 1, we don't know what resistance is, and I'm not even sure that it's clinically relevant. And number 2 or 3, whatever point that is that azole resistance is very rare in the United States, Bernard.
You being an Italian, I would expect you to know the European data, but apparently you don't. So, as many of you already know, resistance in Europe and in other countries to azoles is increasing rapidly. In some of these most recent studies, the rate of azole resistance in these molds was upwards of 30%. And we expect that trend to continue in the United States as we use more azoles for prophylaxis, as they get ingrained in our agricultural processes. So I would argue that resistance is on the rise. So you can take this fancy MIC distribution curve that Anthony showed you, and you can shift it to the right. Now the majority of your patients have high MICs. Now the clinical failure rate is going to be much higher. So with the rise of resistance, you can't take the chance in these patients to do nothing, especially when you might have an azole-resistant mold and might be putting your patient at risk for mortality.
Bernie, I realize you're American, but your geography is very poor. This isn't Europe. We're in the United States. We have very, very different agricultural practices. We don't give azole antifungals in our environment to help our vineyards or our farms. We just don't do that. And so the rise of azole resistance in Europe is not driven by us inappropriately using azoles. It's agricultural practices in Europe. And so, again, we don't see the same resistance in the United States.
I think it's a matter of debate. But why I'm harping on resistance so much is if you're resistant to Posaconazole, you likely have pan-azole resistance. So you can't just switch that patient to Vori, because when the Posaconazole MICs are high, the Voriconazole MICs are also high, as you can see from this chart here.
All right, well, I agree. So, the one person, I agree completely, you should not do a lateral switch. It just doesn't make sense. The only way that it makes sense is when you're trying to fool your physicians to say, hey, we're trying to do something, because you know for a fact that nothing is actually going wrong, and you're like, hey, one fancy drug, okay, let's make it seem like we're doing something. And so lateral switch makes sense when you're trying to confuse people. So I agree with that person who did that. You're very smart.
Would you lateral switch in your mom?
So I would lateral switch in my mom if I felt completely comfortable that this patient was fevering for other reasons.
Okay.
And then I would just switch them to Vori to just shut everybody up on rounds.
You're increasing your mom's mortality rate.
That is not true. So go on this slide, Bernie. Another study from MD Anderson that showed that patients that had azole-resistant aspergillus, these Kaplan-Meier curves are almost superimposable, meaning that there's no difference in a patient that has an azole-resistant mold compared to a patient without azole resistance. They do the same. You're not killing your patient. So why do you keep saying that I'm increasing mortality? So the other point is, if you truly want to go after this azole-resistant mold, you need to start giving them amphotericin. And what if you have a 60, 70-year-old gentleman on your service, or your grandfather, that you're suspecting this in? You have to then commit your grandfather to amphotericin. You're going to blow out his kidneys. You're going to cause him heart failure.
You're blowing things out of proportion here. I would give my grandfather amphotericin B. You're focusing on whether this is aspergillus or not, and if it's a resistant aspergillus, there's maybe no increase in mortality. However, how do you know that this isn't some other mold? What if this is mucor? What if this is fusarium? What if you need to bring out the holy water? In that case, you have no time to be wrong. And we have data that shows that early treatment in these non-aspergillus molds improves mortality in these patients. So let's go back to our patient case, because this is similar to what we talked about. So we did a BAL. He's recovering his counts. What would you do in this patient? He's got a possible IFI. Who would pick A, B, C, or D? Is this one of those things?
No.
Okay.
I don't think it's an audience response.
Well, do you want to take a stab at this?
Yeah. I mean, the black and white is not perfect, right? You can't just say, oh, if this A happens, do B. You got to look at every single individual patient, okay? So if you have a patient that is clinically stable, mucor is not a clinically stable type disease, right? It's either the patient's oxygen requirement is rising rapidly, or you get a CT scan and you got these big goombas in their CT scan. However, if you get a CT and you're like, oh, it's just one nodule, okay, it's just 2 or 3 small nodules, that patient, I would not touch them. I would not succumb them to amphotericin and then make them lose their chance at transplant, okay? Because that's going to increase mortality. So in those cases, I would probably just keep everything the exact same. You can consider then adding your echinocandin if you really want to do something, and I think that's another way to fool people, to think that we're doing more than we actually need to do. But it's also a safe thing, right? Because echinocandin's the only toxicity you're going to get is financial toxicity, which is a tiny drop in the bucket. Jim's drugs aren't even close to how expensive our drugs are. Okay? So in a clinically stable patient, I would argue just let them fever. Do nothing. Stop freaking out about fevers. However, if you have a clinically unstable patient or you have a CT that looks like it's just rapidly progressing, yes, absolutely, you cannot be wrong, and that patient empirically starts something. However, you need to sign a contract with your team and say, hey, you know what? We're going to do 5 days of amphotericin while we figure out what the heck is going on. And I guarantee you that while that patient gets better and while you kind of look at the whole entire scenario, a lot of times you're going to then back off and say, you know what? We probably irrationally and emotionally added amphotericin, why don't we back off a little bit?
And that's what's key, is backing off. And I think we're running out of time here, but we tied that debate. So in the end, it ended up a tie, and we can be friends and have drinks later. So with that, we'll open up the floor to any questions for the three of us. Thanks for listening.
So can we get... All right, this one's on now. That was a fantastic debate, guys. Thank you so much. It was really dynamic. Give it up for our panelists again. Appreciate it. So does anybody have any questions? We have time for maybe one or two. If anybody, just raise your hand. I'll come over. Oh, we got one over here.
Hey, it's Mom.
Hi, Bernie.
How's it going?
Pretty good. Thanks for the awesome presentation. So you guys said that you typically do voriconazole 200 BID for your prophylaxis, and then some patients you do posaconazole. If you don't really know that the person's going to be, able to get into remission and actually, go into reinduction again, at what point do you change that? And then my next question is, do you actually do like TDM for the voriconazole, and what do you usually go for like levels?
Excellent question. You want to take that one or you want?
Sure.
So, it's unpredictable who's going into a remission. Obviously, your core binding factor patients, that's nearly 100% CR rate, no matter what you give those patients, right? So those patients definitely don't need it. And most patients, even your FLT3 patients, you're still pushing like 70, 80% CR rates. So I wouldn't predict CR because we're not going to be able to. Where I would predict CR is when you're doing your interim bone marrows. If you have a day 14 marrow that's completely packed, that patient's going to require reinduction. At that point, you can then consider whether or not to switch over. That patient's kind of in the middle road. However, if you have a patient, you got 3+7, you then gave, say, flag, right? And then they're still not recovering their counts by day 21. You do a bone marrow, you're like, they still have disease. Bam, start posaconazole because they're probably not recovering their counts. That next remission, you're probably going to switch to like a hypomethylating agent, and then their neutropenia is going to be for even longer. And so because that patient's duration is likely to be 30, 60, 90 days, perfect candidate for Mucor coverage.
And the other thing that does is that we're also treating ourselves, and we're treating our ID colleagues. We may have the exact same clinical scenario, but if that patient's on voriconazole prophylaxis and breaks through, your immediate thought is, oh my God, this is Mucor. I need to switch to amphotericin. But if that same exact patient is on posaconazole prophylaxis, you feel more comfortable with these soft call small nodules, calling them aspergillus, and just staying the course or switching to vori in those cases. So it's both to treat ourselves, but also to treat the highest risk patients with our more expanded coverage.
And then you mentioned TDM. So we are starting 200 BID. We do TDM around day 5 to 7 or so, just because we do see a lot of sub-therapeutic levels. Super therapeutic, I don't care. If I have a patient that has vori level of 6 and they don't have neurotoxicity, no toxicity at all, I want my mom to have the highest concentrations of voriconazole if she's not having toxicities. The levels are a surrogate. And then if they have low levels, remember that it's Michaelis-Menten kinetics, right? So don't go from 200 BID to going up to 400 BID. That patient will hallucinate. And those are the problems that we get into, and that's why vori gets a bad rap, is because we, as clinicians, are not appropriately dosing it. So we'll usually fine-tune things by 50 milligram tablets, 100 milligrams at the most, depending on how low their levels are. And then sometimes you get very hyper-metabolizers that come back and they're level 0. Those patients, sometimes you have to just switch to another drug.
I think we're out of time, so thank you everybody for participating in this debate. We have another session coming in shortly.